Hello, everyone. Actually, we have Dr. Ducas here. I'm pretty sure everyone knows Dr. Ducas. For just to say that Dr. Ducas is the actually doctor who started the STEMI code in Manitoba. So a great job a few years ago. And now tonight actually we have pleasure hosting him. Thank you.
Okay, thank you so much. As I said a moment ago, I'm terrified about this presentation because I'm going to be doing something I have not done before. I'm going to be trying to get audience feedback with Slido. So maybe it's going to work, maybe it won't. Let's keep our fingers crossed. This is an interesting lecture for me because I gave it a year ago, a different format of it. And because of this lecture, I actually started working with Shared Health to make a learning module, a series of questions that you can interact with. And this is basically an outline of the work we've been doing with this learning module. So I'll start by sharing my screen. Share. Okay, now I'm going to go to here. Can you see my slide, my first slide?
Yes.
Okay. So here we are, February the 19th at 8 p.m., doing session 66, which is to talk about STEMI versus non-STEMI. Basically, what we're going to do, and my objective here, is to tell you what to do in Manitoba. This is going to be a very Manitoba-centered lecture. And we're going to focus in on what to do with STEMIs and non-STEMIs. I'm going to try to tell you who to call, and I'm going to tell you how to treat. So you see my second slide, I hope? Yes?
Yes.
Yes, yes.
Okay. So I want this to be interactive. I'm going to be asking questions. I'm going to ask you to do a poll. I'll be using Slido, and if you haven't done that, you basically need to have your cell phone with you or a computer, and you would respond to the questions that I'll show. I hope it works. If it doesn't, I have plan B, which is we'll just ignore the Slido. Let's keep our fingers crossed. So if you can scan this or join at slido.com using this number, and we can see on the next slide whether this is going to work or not. Oops. So I hope you see this. Oh, it's working. There's a few people now. 3 people have responded, 4, 6. My goodness, it is actually working. I'm amazed. So you can see here 13, 15 people. The responses are continuing. 17. So 19. So most people have responded. We're up to 20. Almost everybody's figured this out now. And most people work in the northern region. Some people are working in nursing stations. A few people work in Winnipeg, and a few people work in other areas. Okay, well, let's hope that this continues to work. And I'll go on to the next slide so we don't have to be up on this one too long. So, as I said, we're developing a shared health learning module that you'll be able to log on and do this lecture basically on your own. It's in a very much a beta version. It's probably another 6 months before we get it up and running. But whatever feedback you can give me on this format, these questions, I would greatly appreciate it. Now, I'm going to assume for the rest of this lecture that your location is more than 100-minute drive from St. Boniface. And the reason I'm using that 100 minutes is, as you'll see in a moment, that is basically the farthest we would try to do primary PCI if someone has a STEMI. Anybody that is any patient that's greater than a 100-minute drive from St. Boniface, then we would most likely recommend lytic therapy. So we'll make the assumption on the next few questions that this is regarding patients greater than a 100-minute drive from St. Boniface, who, if they do have a STEMI, would be suitable for lytic therapy. Now, what is a 100-minute drive? This is from MTCC, the Manitoba Transport Coordinating Center, and 100 minutes is all this yellowish area. So if you're at Hodgson, you're a little bit beyond it. If you're in Notre Dame, if you're in Pine Falls, in Gimli, then you should be able to get your patient to St. Boniface within 100 minutes. So take a quick look at this. This is basically the footprint of who could get to St. Boniface Hospital if they have a STEMI for angioplasty. Now, we have a couple of modules which I'll talk to you about, not modules, algorithms, which I'll talk to you about in a moment, our STEMI algorithm and our chest pain with cardiac features algorithm, which I hope you'd be able to use. I think that they're quite simple to use and can guide therapy in the appropriate patient. How do you find these modules? If you Google Cardiac Sciences Manitoba ACS, the first thing that you'll see is acute coronary syndrome ACS network. And when you hit that, you'll see this first page. And if you hit referral to ACS pathway, what you'll see is our STEMI algorithm and our chest pain with cardiac features algorithm. So that's basically what I would recommend you use if you want the information that I'm going to give you over the rest of this lecture. Here is our STEMI algorithm. And basically what it does is it tells you what to do if you're in Winnipeg or not in Winnipeg. It tells you the drugs to give prior to transport. If there's a patient with a STEMI that's going to have a PCI at St. Boniface, again, that's within a 100-minute drive. And it also tells you what to do for TNK, giving you a breakdown according to patient's age regarding the different dosages. And it also it gives you quick access to the contraindications, both absolute and relative, to lytic therapy. The chest pain with cardiac features, again, it has a lot of information here. It helps you identify who's an unstable or high-risk patient, which really needs urgent transfer. It gives you all the medications and treatment to give in unstable patients. It gives you the vectors number to call. And it also, for lower risk patients, it walks you through exactly what to do. And if you have an option, if they're very low risk, you have an option to discharge the patients. If they're intermediate risk, to recommend admitting them. And all of this works on the so-called TIMI risk score, and it gives you a simple table here to allow you to calculate it. So that's the preamble. Let's get into the first case. So case number one is Steve. He's a 67-year-old man. He presents, to someplace far away, greater than a 100-minute drive, an emergency department or a nursing station, and he's chest pain with cardiac features. He appears stable. He says the pain started 3 hours ago, and it started at an 8 out of 10. It's a little bit better at 4 out of 10 now. So the question is, what does the care team do first? Do you perform full triage assessment, including vital signs? Do you request immediate ECG? Do you draw blood work, including troponin? Do you obtain vital signs? So if you can vote on this, I hope you can do that like you did on the first one. We'll see what people think. Okay, we're up to 22, and most people think you should do full triage assessment, including vital signs. I find this quite interesting. So what people thought was this, full triage assessment, including vital signs. So what would happen possibly? Well, 30 minutes later, an ECG is performed, STEMI diagnosis is made, and this results in delay. This delay results potentially in a larger infarction for Steve. This actually is not the best option. Although triage assessment is important to document early, priority really must be made in getting the ECG to determine if a STEMI is present. So the actual correct answer here is request an immediate ECG. While you're getting the ECG done, while you're getting things organized, getting the patient into the stretcher or some place where you'll do the ECG, you can start getting some other information, you can start checking the blood pressure, but the first thing you should be doing is getting the ECG. And an ECG hopefully was performed quickly in less than 8 minutes. The recommended standard is less than 10 minutes. And ST elevation is seen in the anterior leads. And here's a picture of what that might look like. Here's a 12-lead ECG. Here are the anterior leads, and you can see ST elevation right off, very easy to see in this 12-lead ECG. So that's the best option. Outcomes are significantly better when an ECG is performed in less than 10 minutes from first medical contact. It's been shown that delays of as little as 10 minutes to treatment to reperfusion can increase mortality in a STEMI. And I'm sure you've heard the saying, time is muscle. Now, I'll give you some additional information, and we've been working on this very hard in Winnipeg, but whoever sees the patient first should request an immediate ECG. If you're in a small facility, a nursing station, that's likely a nurse or paramedic that's working there. But actually in hospitals like St. Boniface or Health Science Center in Winnipeg, it's actually a registration clerk that sees the patient first. And if registration clerks are at your location and not empowered to request an immediate ECG, then please contact us at the ACS network for further information. Getting an ECG in less than 10 minutes is really, really hard. And I'll give you some data. This is Brandon Hospital, Health Science Center, Victoria Urgent Care, Concordia Urgent Care, St. Boniface Hospital, Grace, Seven Oaks. And these numbers here in lines are over 29 months, a little less than Brandon. And the numbers here are the minutes from first medical contact to ECG in patients that come to these different facilities saying, I have chest pain. And this is chest pain with cardiac features. And you can see most of the hospitals in our province, it's 25, 30 minutes from first medical contact to ECG. St. Boniface, the heart center, it's not even regularly achieving or hasn't once achieved a median time of less than 10 minutes. On the other hand, Grace General Hospital, we've been working with them very intensively, and they've over time, because they get the registration clerks to ask, for the ECG to be done right away when they confront a patient who says, I have chest pain, they have over many months reliably obtained these ECGs. So this is a work in progress there we're working on in the city. But I just pull this slide up or show you this slide just to emphasize that the first thing that should be done if somebody comes in with chest pain with cardiac features, as long as they're obviously not in severe distress, is to ask for an ECG. And then you can at the same time get the blood pressure and everything else done. So let's say that the STEMI diagnosis is certain, just as it was, at least from the CCG. The team should check for any absolute contraindications by following the STEMI algorithm that I showed you before. And you can quickly ask the patient a few questions to rule out any absolute contraindications. I won't go through this all, but it's quite simple. Have you ever had a bleed into your brain? Do you think the patient's having a dissection? And there are some relative contraindications that you can see again. You can look at your leisure, like very high but any measurement of very high blood pressure is a relative contraindication to TNK. So here we go. Here's the next question. So you've done the ECG. You see what you think is a STEMI. You've ruled out that there's any bleeding contraindications. What should you be doing next? Should you be calling vectors for the code STEMI doctor to get further confirmation? Should you go ahead and administer fibrinolysis? Should you wait for the troponin results to come back? Should you repeat the ECG just to make doubly sure? So you're up to 16, 19, 21, 26, 28 people. Okay, so the majority of people actually said administer fibrinolysis. So let's go here, administer fibrinolysis. A lot of people said number one, call vectors for the code STEMI doctor. I'll show you this, and I'll tell you, although most people got the answer right, which is number three, I'll show you why this is wrong. Once the code STEMI doctor is reached, if that was your answer to call the code STEMI doctor, and the case is reviewed and STEMI diagnosis is confirmed, this took an extra 10 minutes or so to do all of this. And it's not the best option, because if the diagnosis is certain, if you're sure that this is a clear-cut STEMI, there's nothing else going on, you have no doubt in your mind, do not delay treatment by calling vectors. You do not need permission to administer fibrinolytic therapy in this province. And that's true whether you're at a nursing station or anywhere else in the province. If you think that this is a STEMI, don't waste time calling and getting permission. You can go right ahead and you can administer fibrinolysis. And here we go. I'll take that off. That's the correct answer. Fibrinolytic therapy stops the progression of the STEMI by dissolving the causative blood clot. It's the best option. Give TNK first. If you're certain the patient has a STEMI, an OK from cardiology is not needed. Even 10-minute delay can increase mortality because time is muscle. Okay, here's the next question. As part of fibrinolysis, which medication did the care team administer? Now I'll walk you through this. It's a little complicated, but it's an IV dose of enoxaparin, a sub-Q dose of enoxaparin, clopidogrel 300, aspirin 162. That's the first option. Same enoxaparin IV, same sub-Q, clopidogrel 600, and then aspirin. Or enoxaparin 30 IV, 1 milligram per kilogram, sub-Q, clopidogrel 600, aspirin 162, and then finally enoxaparin 30 milligrams, 1 milligram sub-Q, 600, and aspirin. It's all anonymous, so if you put something on, no one's going to know what you voted. Don't worry about it. Okay, we're up to 26 people, and actually, you got the answer right. Let's go to the next slide. Enoxaparin 30, 1 milligram per kilogram sub-Q, clopidogrel 300, ASA 162. That's the right answer. It's the best option. The clopidogrel loading dose should be 300. Now, if you're not dealing with a STEMI, if you're dealing with chest pain and non-STEMI, a loading dose of clopidogrel is actually 600 milligrams. But when you're using TNK, the correct dose is 300 milligrams. Now, there's another important thing, and that's age. Less than 75, 75 or older, this is taken from the STEMI algorithm, which you can easily get a hold of as I showed you. And the key thing is older people, they get a smaller dose, or first of all, they don't get any IV enoxaparin, just sub-Q. and they only get 0.75 milligrams per kilo and a maximum of 80 rather than 100. And they get only a single tablet, 75 of clopidogrel rather than 300. Now, you might think, why is he showing this? It's on all the order sets and everything. I'm one of the code STEMI doctors. I receive code STEMI calls all the time. Probably every third or fourth night I'm on call for code STEMI, there's been an error in a patient that got TNK. It's just incredible to me. I was on last night and there was an error in dosing. So this is something that's really important. You've got to pay attention to this. And if you sort of just say, well, follow the protocol, somebody's going to get this wrong, the nurse or somebody. Always double check and be very, very meticulous about this. Now, the other thing is one time we had a delay because enoxaparin had been given ahead of time by an ambulance attendant, and it doesn't matter for the enoxaparin as specified on the previous slide. It can be given before or after the TNK. The correct doses are specified in the STEMI algorithm. Always double check. And if you think there was an error, let the coach STEMI doctor know if you think that it was a dosing error so that we can act accordingly. So the wrap up for this case is the care team arranges transport to St. Boniface through Vectors. There's the Vectors phone number, 204-949-4000. EMS is instructed to call Vectors en route if 30 minutes prior to arrival, the patient has chest pain. And that's something that we always ask, because if the patient's pain-free post-TNK, you can go to the emerge. If he's still having pain or has recurring pain, patient should go straight to the cath lab, and Vectors should be told if pain returns. Recurring chest pain suggests coronary reocclusion, and immediate cath and PCI is indicated. Resolving chest pain suggests that the artery is open, and a non-emergent cath should be done sometime in the first 24 hours. So here we go to case number 2. Kamal, who's 80, arrives in the emergency department by ambulance. Or if you're in a nursing station, by whoever's friend that you brought him in a pickup truck or however he got there. The story is he had syncope after taking nitroglycerin for chest pain. He was complaining of some shortness of breath. He took some aspirin at home. His chest pain's resolved, but he just doesn't look right. He's uncomfortable and he's sweating. 5 years ago, he presented with stable angina, and this resolved after a PCI he had 5 years ago. He had an angioplasty and stent. 4 weeks ago, he had anginal chest pain start up again, and it's now CCS3. Minimal activity is causing him to have chest pain, anginal chest pain. He recently saw a cardiologist, and a coronary angiogram as an outpatient was ordered. When he comes in, his blood pressure is about 100, his heart rate's about 75, his respiratory rate's 20. It's a little bit hypoxic. An ECG done by the paramedics before he came in, which was done less than 10 minutes from first medical contact, was done. Patient is now chest pain free. Here's the ECG. You can see here that he's got a PVC. He's otherwise in sinus rhythm. He's got a left axis. He's got some ST depression in V2, V3. He's got perhaps some Q waves in lead V5 and 6. But the key thing is there's really no clear ST elevation. This is not a textbook STEMI, but there are non-specific abnormalities. They may be old, they may be new, we don't know. So what does the care team do? I think you'll get this one right. Should you just have him wait? Send him to the waiting room? Should you draw blood work because the pain's resolved? Should you ask for a chest x-ray because he was a little short of breath? Should you expedite him to some monitored treatment space, some place where, he could be watched more carefully? Okay, that's interesting. So most people think that you do the blood work, chest pain's resolved. Uh, some people think monitored treatment space. Okay, let's go and see what the right answer is. Well, here's the answer that most people thought. The chest pain's resolved. You put him there, he has another episode of chest pain in the waiting room. This is not the best option. And you have to look at this in the whole big picture of this patient. He's elderly, he's 80, he's had a previous PCI. You know he has coronary disease. For the last month, he's been complaining of chest pain. He had chest pain today, took some nitro and fainted. And he saw a cardiologist, and the cardiologist was so concerned that the cardiologist ordered a coronary angiogram. So this is really not the best answer because of this patient. If you didn't have all this other background, yeah, it would be the right answer. But because of this particular patient, the right answer is put him into some place where you can watch him carefully. He's placed on a monitor. His vital signs are repeated. His blood pressure is even a bit lower. He has recurring chest pain. Because of the low blood pressure, he's given a little bit of saline. This is the best option. That's because, given the story, he likely has critical coronary disease. Given this blood pressure, he's likely in early cardiogenic shock. And again, if you go to the STEMI algorithm, or sorry, the chest pain with cardiac features algorithm, which I'll show you in a moment, it walks you through this. Even if there's no beds readily available, the care team should recognize that Kamal is unstable. He requires monitoring, and he will require an urgent cath. Now, this is actually a true story. There was a patient that presented like this, and this patient ended up as a critical incident. And this patient was the reason I made this presentation. So this is something that actually happened. So here's that algorithm, chest pain with cardiac features. And what it does is it says the first question it asks you is this patient unstable or high risk? And by unstable, we say recurring or ongoing chest pain, refractory to medical therapy, or hemodynamic instability, or arrhythmias or dynamic ECG changes or heart failure. And if the patient that you have has any of these things, and this guy had, in fact, recurring chest pain, his blood pressure was low, it then tells you what to do. Give supportive medical therapy, initiate treatment for ACS for a patient that requires immediate coronary angiography. If it's not contraindicated, it gives you aspirin doses, heparin or enoxaparin doses. It mentions beta blockade if appropriate. It mentions high dose statins if possible and telemetry. And the last thing that it says is about giving clopidogrel or ticagrelor, and it says no P2Y12 in high risk unstable patients recommended for immediate coronary angiography. And once again, you get the vectors number here. So which medication should be administered? I just told you these things. Maybe we won't vote here. What I will do is I will go to the next slide because I just walked you through it. So what would you do? Well, would you give him aspirin and fractionated heparin, or if you don't have that, enoxaparin plus atorvastatin? Well, no, because he's already taken the aspirin. Um, so I wouldn't do that. Clopidogrel 600, no, because he needs an angiogram today. And vectors and stars should be able to get this patient to the cath lab in less than 24 hours. So you would not do that. You would give unfractionated heparin or enoxaparin, 0.5 milligrams per kilo, plus atorvastatin. You would not give metoprolol because he's already potentially shocky. So the correct answer is here. This is the best option. These two medications, an anticoagulant or enoxaparin or unfractionated heparin plus atorvastatin. And for non-STEMI patients who undergo immediate coronary angiography, if you do have unfractionated heparin, it's preferred by the cath lab, but if you don't have it, enoxaparin IV is fine. Enoxaparin 0.5 milligrams per kilogram IV. And you can say, what's he talking about giving atorvastatin? Well, even short-term atorvastatin has been proven protective in urgent PCI. As crazy as that sounds, there was actually a meta-analysis of atorvastatin before percutaneous coronary interventions, even short, 1 day. And this was published just a year ago. And it showed actual reduction in death in MI, or at least large MI, in patients that got the statin. So as crazy as it sounds, giving an oral statin is important in this situation if you can give it. So vectors is called, cardiologist advises immediate transport for cath, the blood pressure remains soft, his heart rate now is higher, he's borderline hypoxic even with some oxygen, coronary angiogram shows 3-vessel disease, he gets 3-vessel PCI, his blood pressure stabilizes because he was treated quickly, he's sent to CCU, his course was subsequently uncomplicated, in 72 hours he was discharged. Now, this is the happily ever after ending. Actually, this patient died. So I wanted to make it a positive thing, but the patient that this was based on actually had worse and worse shock and died, and he had 3-vessel disease, could not be fixed. Okay, case number 3. 52-year-old female presents with 1 hour of nausea, shortness of breath, and diaphoresis. No chest pain. Never felt this before. No history of cardiac disease. On no other medications at all, not on any medications. And she says, her brother had a heart attack at age 50. So there's a family history of premature coronary disease. But otherwise, there's nothing else. No chest pain, nausea, shortness of breath, and diaphoresis. So what does the care team do first? Perform full triage assessment vital signs, draw blood work, including troponin, obtain vital signs, request the ECG. Geez, I'm not going to fool you twice here. Okay, I think most people are not falling for the trap here. Most people are getting this right. It's to do an ECG. And the reason for that is here. Request an urgent ECG. An ECG is performed in less than 8 minutes. Here's the ECG. You're looking at this thing and, it's not right here. It's just not right. It's sinus rhythm. There's some atrial premature contractions. There's borderline ST elevation, maybe in lead 1 AVL, maybe. And there's ST depression in lead 2, lead 3, a little bit in V1, V2, V3, V4. So they're just not right, but it's not clear. It's not a clear-cut STEMI. Oops. So when you see an ECG like that, what should you do? Should you repeat the ECG right away? I'm going to go back. Somehow it's skipped there. Should you repeat the ECG right away? Should you ask for a 15-lead ECG? Should you call Vector and get advice from the cardiologist? Should you order an X-ray? Okay, so most people got the right answer here. Very well done. So let's go to the next slide. So the correct answer is to do a 15-lead ECG. This is the best option. ST elevation, when you do that, is now seen in the other leads. So if ST elevation is suspected, or ST depression is seen in V1 to V3, then do a 15-lead ECG. And this is the 15-lead ECG. Here's V4R, V8, V9, and you see a little bit of ST elevation in V8 and V9. And the key thing is that in V8 and V9, you don't need the standard 1 to 2 millimeters of ST elevation. Here, just half a millimeter of ST elevation, either in V4R, which is this lead, which is a right ventricular lead, or V8 and 9, which are the posterior wall leads. Even the smallest amount, 0.5 millimeters of ST elevation, is abnormal and suggests occluded vessel, suggests STEMI. A 15-lead ECG improves the detection, especially in the posterior area, especially for right ventricular infarction, and you need less ST elevation. All you need to see is half a millimeter in these leads, and that's abnormal. And if you see ST elevation in V, that should, this is if you see ST elevation, ST depression, sorry, if you see ST depression in V1, V2, you should suspect a posterior infarction, and you should ask for V8 and V9, which will better demonstrate that area of the heart. So the wrap up for this case is the code STEMI doctor is eventually consulted. He advises fibrinolytic therapy. You could have given it all on your own, didn't have to call if you thought it was clear cut. Anna is still having ongoing chest pain 30 minutes before arrival. Perhaps she's coming via Stars or Life Flight or however, and in the ambulance on the way to St. Boniface or at the airport, she's still having chest pain. The paramedics are told, call the code STEMI doctor through vectors because of ongoing chest pain. The lytic therapy failed, told directly to the cath lab. A blocked circ was found, PCI was successful, pain-free, discharged 2 days later. So the point here, the final point is that if after you get lytic therapy, you have ongoing chest pain, that's failure of the TNK and rescue PCI is indicated. And that's why we tell the paramedics, you know, let us know 30 minutes before arriving to St. Boniface if the patient's still having chest pain. Okay, we'll go to the next case. Miriam, 72, presents with 4 hours of dyspnea, weakness, lightheadedness. She denies chest pain. There's no cardiac history. She is on some antihypertensive medications. And for reasons that, sometimes you stumble across patients that are on low dose aspirin and there's no clear reason why. And in her, there's no clear reason why. When you check her vital signs, they're perfectly fine. So what is I'm going to not even ask you because you'll know the right answer here. Request an immediate ECG. That's right, you'll know that. I won't wait for everybody to do that. I'll go to the next slide. So the correct answer here is request an immediate ECG. Now the ECG is basically normal, no ST elevation. So, her symptoms may be related to ACS. Older patients and females may have a STEMI without chest pain. So you have to keep that in mind. And we have a poster here, and if you want this poster, I'm happy to give it to you. And it tells you, and this is from data on STEMI patients, that as you get older, or especially in females, the symptoms are no longer just chest pain. Somebody comes in, that's young, and they have chest pain, they often have a STEMI, but a young person usually won't present with unusual, sweating or other things. A young person with a STEMI usually has chest pain. But as you get older, especially with females, you may not have chest pain. And a stat ECG is indicated for somebody that's just sweating or short of breath or have upper body discomfort or weakness or lightheadedness. And in older people, even nausea or abdominal pain can be the presenting features of a STEMI. So that's why you should be always cautious about this. And we have this poster available so that whoever is empowered to ask for an ECG can refer to this and get the right clue as to which patient might benefit from an ECG. So this is Miriam's ECG. It's perfectly normal. So what what happens next? I forgot something here. Miriam does have blood work. She does have an elevated troponin. It's 2 times the upper limit of normal. So she comes in with unusual symptoms, not complaining of chest pain. She does have a mildly elevated troponin. What should you do? Should you do it? Should you calculate out a TIMI score? Should you call vectors for immediate transport because her troponin's elevated? Should you call the cardiologist to arrange for an early inpatient angio? Should you discharge her because she's not having pain? What should you do? Normal ECG, troponin 2 times the upper limit of normal. Okay, most people are going for calculated TIMI score. And that indeed is the correct answer. So we can go to the next slide. So calculate the TIMI score. The TIMI score is 3. Miriam is at increased risk of a poor outcome without an early coronary angiogram. She's admitted and cath is requested. This is the best option. Some people like to use the heart score. There's also the gray score. You can certainly use it instead of a TIMI score. The important thing is to risk stratify a patient. If there was no troponin rise, then the risk would be very low because the patient really doesn't have much of any problems at all. And you might even opt to discharge the patient. But given the risk score is 3 or higher means a patient that is at increased risk. So this again is on our algorithm. You can very simply calculate it out. It's a total of 7. And if you have 3 or more, 2 greater than 2, that puts the patient at high risk. You can also, search for MD calculation. There's an automatic calculator that you can do on your cell phone. And again, it'll calculate out the points. But if someone has 3 or higher, greater than 2, that's somebody that needs admission and cath. A cath referral is sent. She's admitted for cardiac monitoring to your facility. 48 hours, she gets to the cath lab. She has a tight lesion in her distal RCA. She's repatriated back. There's a few points I'll just mention. Just like TNK, you don't need permission to ask for a cath. If you think the patient is at risk, if you do the TIMI risk score and it indicates a patient should be admitted and cathed, you don't need to call vectors. You don't need to speak to the cardiologist. You can simply fill in a cath lab referral form and fax it in or send it in. You don't need permission for that. Our cardiologist doesn't have to be told. If the patient's low risk, if you calculate 2 or less, then you may even go ahead and refer the patient to an internist or cardiologist that might be able to do a stress test. As long as you tell the patient, please come back to the emergency if you have recurring symptoms. So at nursing stations, or if there's no monitoring option at your facility and the patient will require transport until the cath can be arranged. And if you want to do that, call vectors 949-4000. to speak to the cardiologist if you can't manage the patient. Okay, so that's what I wanted to show you. I'll open up for questions in a moment, but I will ask for some feedback. Anonymously, tell me what you thought about this. 1 to 5, not helpful to helpful. Okay, well, most people were happy with this. And, again, if you can give me some feedback, and then we'll open it up for questions. And again, this is important because we are doing the learning modules, and I want to make sure that we have good modules. So if you can get me some, give me some feedback, I would greatly appreciate it. Okay, well, thank you. Regarding more ECGs, I'm certainly willing and able to do an ECG session for you. And I think that's possibly being scheduled, and I'm happy to do that. So I'm going to stop sharing my screen now so I can look at people or talk to people, or they can look at me. So any questions or comments or anything that you'd like to tell me about all this?
Hi, Dr. Ducas.
Yeah.
My name is Pravina. I'm working at nursing stations in Thompson.
Okay.
I just wanted to clarify something from the last slide. So if someone at a nursing station is TIMI 3 or more, um, do they all go to St. Boniface to await their cath, or does anyone ever get transported to Thompson for cardiac monitoring until their cath?
Well, you could do that. You could send the patient to Thompson or Brandon or any place that can handle the patient. The thing is, though, they're going to be cathed,
Yeah.
and may as well just send them to St. Boniface. It's just one transport instead of two. So, and St. Boniface, will accept the patient. I've never heard of a time where we said send the patient somewhere else. So sure, you can send them to Thompson for sure. And sometimes from nursing station that happens, but they're going to end up anyway to get the cath at St. Boniface, and we will try to accommodate them.
Okay, thanks for clarifying that.
Yeah. Any other questions?
Hi, Dr. Ducas. Thank you so much for this pleasant lecture. My name is Dr. Farag. I'm from Verdin Hospital. I'm just have a question that might face everybody like me. So most of our patients who come with non-STEMI or unstable angina or STEMI, they have DUAC or warfarin. When it comes to the transition to TNK or the algorithm to start the other antiplatelet or anticoagulant medication, should we stop DUAC right away? Should we stop warfarin right away? What is the best approach to do this?
I think you're going to have to call the cardiologist and discuss it because, there's different indications for different reasons that they're on it, different preparations, whether they're on warfarin or whether they're on the DOAC. But I don't think it's going to affect the immediate care. When the patient comes in right away, if they're not on an antiplatelet drug, they should at minimum get aspirin. You can wonder whether, a P2Y12 like clopidogrel or ticagrelor is also needed, but the minimum is an aspirin for sure. And then after that, if the patient has an indication for a cath, the patient's going to go to St. Boniface. That's probably a patient that you may not want to keep at your facility, or in discussion with the outside call cardiologist. At that point, you can decide the strategy for the antithrombotic therapy. So I don't want to give you sort of a one size fits all answer. I want to say always give an antiplatelet drug if they're not getting that, in other words, aspirin, because some of them are not on aspirin. That's the first thing. And the second is, depends on the circumstance, it's going to require a discussion with the outside call cardiologist. So call Vectors, 949-4000, and Vectors will get a hold of the cardiologist, and you'll be able to work out a strategy for that.
Yeah, thank you.
Yeah. So I'll ask you for some other feedback. How are people finding Vectors? Is it working out okay for people, or are you having frustrations with it? I can tell you what I think about it, but anybody have any comments they might want to make about Vectors?
Hello, Dr.
And
Ducas.
let me know, because I'm happy to give them feedback. I work very closely with them.
Hello, Dr. Ducas.
Yeah,
Hi. Yeah, when we call vectors, my name is Labib, by the way, I work at
yeah,
CME. We had to try to call vectors for, say, for emergency. If you are a resuscitating patient, press one. I was resuscitating a kid, 3 months old baby, a few days ago, and we pressed one. We put us on hold for some reason, and we tried that 3 times.
no,
Okay, this is one point. One thing. Also, when we try to transfer patient, or we have now to call the emergency, and we call victors both times, and they have to speak to one physician in the transfer team.
So you're now having to talk to more than one physician?
Yes.
Okay, well, I'll give that feedback. I know both Dr. Gerson and Sokol who are leading that, and I'll let them know that there's some problems with the press one, emergency, and also two physicians are being involved.
Yeah, I have I have to, for example, to arrange for a transfer to the patient, I have to call the Okay, call vectors, call emergency, and arranging for the transfer to the emergency and I have to call vectors and speak to the vectors doctor too, same time.
Yeah. The idea behind vectors is one phone call, one discussion, and that's unfortunate that's happening. They're supposed to get everybody on the line together. In other words, have a party call. So if they're making you call multiple people, but I'll give that feedback, and I'll
I got
certainly
the
give
same. Yeah, I got the same feedback too from my colleagues too during their emergency.
Okay. There was a question about aspirin, if someone's allergic to aspirin, then basically what would be recommended at that point would be use ticagrelor. And if you don't have ticagrelor, well, 600 of clopidogrel, but a loading dose of 180 of ticagrelor is the best. And the reason for that is it works the fastest and it works just as good as aspirin. So if there is any question about allergy, and you can certainly use single antiplatelet therapy, you don't need dual antiplatelet therapy in all situations. So if there's an allergy issue, use ticagrelor. Let me see if there's any other questions. Allergic to aspirin. Can I clarify nursing station greater than TIMI? All I do is go to say and wait for cath. Or do the patients get, yeah, we've already talked about that going to Thompson. I don't recall about the chest pain for more than 3 hours, but we'd have to go back to that question. That's okay. I don't think it's important. I'm glad it called first. Okay, good. Some people have had a good experience with vectors, which is nice to hear. I would rather prefer to send EKG quickly to STEMI physician via Tiger Connect. Yeah, as the STEMI doctor, I've actually enjoyed doing it through vectors because I get all the demographics. I often will get the ECG, but it's still early in vectors. I hope people are patient with it, and I'll give the feedback that you've given. Any other questions or comments?
Thank you, Dr. Ducas. It was a great session again. Thank you for your
Okay.
time.
Well, it's nice talking to everybody.
I
You
have a
have a
quick
good evening.
question, if you can hear me.
Yeah.
In terms of like for NSTEMIs, I know on some of the algorithm forms, like when I was out at one of the rural sites, out in Winkler, there's a suggestion on there that mentions like either starting a beta blocker or a like an ACE inhibitor. When do you typically consider doing that for the lower TIMI scores when you're waiting for like an angio?
Oh, I think it really basically depends on the patient's, background, and, if the patient's looking like they're a little tachycardic, especially if they're hypertensive, you may want to lean a bit towards a beta blocker. If the patient, has hypertension, again, an ACE inhibitor. It's just what you would ever typically, or what you would typically do when dealing with a stable patient that has, hypertension. People that are low TIMI risk score, the chance of them having infarction in the next month is quite low, and you're relatively safe. And just use basic first principles of how you'd handle any patient that comes in. If they don't have hypertension, I would not necessarily give a beta blocker or an ACE inhibitor. But if they come in, they seem to be somewhat hypertensive, you may, opt to use that, again, in the clinical context, using all the guidelines that you would use in treating a hypertensive patient.
Thanks.
I hope, yeah. There's a maid has a hand up.
Yes, Dr. Ducas. Sorry. So first of all, thank you so much for this presentation on the Slido, and it really helped actually for getting the knowledge. My question was that you said you had a plan B if the Slido won't work. So I just want to know what would be your plan B?
Well, slashing my wrist, that would be one of them. I was just going to ignore those slides and just, ask people to put hands up and vote that way. But I don't think that would be a very good way to do it.
Okay, well, something. Thank you so much.
Okay. But it seemed to work, thank goodness. Okay, well, we're 2 minutes to 9. It was nice to interact with you guys. Have a great evening. And
Thank you very much,
if you want me to be back for an ECG session, no problem.
Yes, I think we already arranged it.
Yeah.
I cannot recall the date, but for sure we will have it.
Okay, great. See you then.
Okay, thank you. Take
Yeah,
care. Bye.
bye-bye.